Okay, so let's look at the respiratory system. So, you've all often heard when you go to the doctor, when you have a common cold or a sore throat, and the doctor says, oh, you have URI or upper respiratory infection, right? And then sometimes you may have heard of somebody having severe lung infections like pneumonia, and maybe they have pleural effusion where the pleural cavity is filled with fluid. And then they say, oh, they've got a lower respiratory infection. So let's see how we kind of divide the respiratory tract, and this is more for clinical purposes. It's divided into an upper respiratory tract and a lower respiratory tract. The upper respiratory tract, as you can see, is from the nasal cavity. This part here is the nasal cavity, the pharynx, and the larynx. So you come down till the larynx, and that's the upper respiratory tract. So up to the larynx, that's the upper respiratory tract. And then the lower respiratory tract is from there downwards, like the trachea and the bronchi. The trachea divides into bronchi, and then these go into the lungs. So all of that is the lower respiratory tract. The bronchi actually continue to divide into something known as bronchioles, which are, you remember, arteries divided into arterioles. So we have bronchi, which divide into bronchioles, and bronchioles are about 1 millimeter. When it comes to about 1 millimeter in diameter, then we call them bronchioles, and the terminal bronchiole is a little smaller. It's 0.5 millimeter. Then we have another division. So that was like an anatomical, clinical division, an upper respiratory and a lower respiratory. And then we have a functional division where we divide it based on whether there is gas exchange or no gas exchange. So it's called conducting zone and respiratory zone. Conducting zone is where there is no gas exchange occurs. So no gas exchange occurs in this area. And respiratory zone is where you do have gas exchange. So you do have gas exchange. So the conducting zone is, we call it the conducting zone is because it actually carries the air. It has to transport or conduct the air till the final point where now gas exchange can take place, okay? So this is all the way from the nasal cavity. So you can see all the way from the nasal cavity, going down the pharynx, larynx, it goes into the trachea, and it comes down to the bronchioles. Remember, I just told you the bronchiole was when it was of a diameter of 1 millimeter, and bronchioles begin to lose cartilage, so they just have smooth muscle around them. And in fact, a bronchiole, when it kind of reaches the end of what we will call bronchioles, it's known as a terminal bronchiole. Terminal is from now on something else is going to come. So a terminal bronchiole is 0.5 millimeters in diameter, whereas a regular bronchiole is 1 millimeter in diameter. So from the nasal cavity down to bronchiole, when I say bronchiole, I mean till the terminal bronchiole, because these bronchioles also keep dividing, so they get smaller and smaller and then reach a terminal bronchiole. So that's the conducting zone. And then the respiratory zone is from the next portion where you see the word respiratory bronchiole. So there is a structure in the lungs called the respiratory bronchiole. From there up to the alveoli, that's the respiratory zone. I have in your notes, I have histology given, so we won't be doing the histology, just kind of read that on your own. And here you can see, if you look here, so here all the way from the nasal cavity, pharynx, larynx, and you see you're getting into the trachea, it's dividing into bronchi, bronchioles, and then the final terminal bronchiole. All of that is conducting zone. And then we have respiratory bronchioles, which lead into alveolar ducts and alveoli. So here you can see up here, this is a terminal bronchiole. So till this point is conducting. From here it leads into alveolar ducts, and then you can see all these alveoli and respiratory bronchiole a little higher up. And here you can also see, I want you to see these pulmonary capillaries, which are kind of forming a little network around the alveoli, and this is where that gas exchange takes place. So here's where you can see the respiratory and the cardiovascular system are really interacting with one another. And these pulmonary capillaries are actually present in between a septum, which is present between the alveoli, and that is known as the interalveolar septum. And later when we do the respiratory membrane, we'll talk about it. So if you look at it, so you can see the alveoli are like walls. So they are like walls. Imagine a room with many walls like this. And in between them, this area is the interalveolar septum, the septum between them. And this is where you have the pulmonary capillaries. So I'm just going to, the deoxygenated blood present here like this. And here, from here, the carbon dioxide goes into the alveoli. The oxygen from the alveoli will go into the capillary. So that end of the capillary will continue and form pulmonary veins. If you remember, the pulmonary veins carried oxygenated blood, right? So that's how you can see the red and the blue, okay? So these capillaries are present in the interalveolar septum. Now, let's look at this question. I told you structurally or anatomically, and I said functionally speaking, we divide it. So the upper respiratory tract belongs to entirely to the conducting pathway. Is that true or false? True. Remember, the upper respiratory tract is from the nasal cavity to the larynx. And the lower respiratory tract was the trachea till the alveoli. So the upper respiratory tract is entirely conducting because the conducting pathway was from the nasal cavity down till the terminal bronchiole. So here you have it includes the upper respiratory tract and part of the lower respiratory tract, right? You understand that, isn't it? The conducting pathway. Now here are some important facts that you should, they're more interesting and things for you to remember. Alveoli continue to develop in us. So, when the fetus is developing, there's little areas called lung buds which will finally form the lungs. But alveoli continue to develop in a child after birth. In fact, after birth till about 8 years, that's when more of the respiratory bronchioles and alveoli develop. And as you can see up here, 95% of the alveoli develop after birth. So that's why when children are born very prematurely, they can't breathe on their own because they don't have enough alveoli and respiratory bronchioles to help them. Yes?
Does that mean that a child under 8 is more susceptible to damage from secondhand smoke because they're developing?
Yes, anything more susceptible. Anything during the developing period of secondhand smoke or anything else. In fact, I have a question. You kind of preempted that, and you'll see that question being asked about it. Yes, and during development, anything which is injurious absolutely affects them more. Yes. And then in the alveoli, when you look at the lining of the alveoli, in ANP1, you did this. Alveoli are lined by simple squamous epithelium, right? Because you want the epithelium to be thin so that it allows diffusion of gases to take place. Now, in between this simple squamous epithelium, actually you have a few cuboidal cells. So these are the simple squamous, and here, like this, is the cuboidal cells. The simple squamous epithelium are what are called the type 1 cells. And these help to form something which we'll see later, which is called the respiratory membrane. The membrane across which diffusion occurs. These cuboidal cells are the type 2 cells. And these type 2 cells they produce surfactant. Surfactant is something which is important because whenever you have fluid, have you ever taken 2 glass slides and you put a little drop of fluid between them and you try to move the glass slides? You can move them one over the other, but you can't pull them apart. Right? And that's because of the surface tension. Water molecules tend to adhere to each other. Similarly, inside an alveolus, if you look at an alveolus, water is kind of flowing down all the way. So let's look at this previous picture here. So here, fluid, it's kind of mucus and other things which are produced by the nasal cavity, which contain water. All of that flows down and they begin to coat the alveoli very, very lightly. These water molecules have something which is known as surface tension. So they have a high surface tension and they tend to stick to each other. So water has a high surface tension, which makes the alveolar walls want to stick to one another. So if the alveolar walls stick to one another, what will happen? The alveoli will be collapsed, isn't it? It'll be like those glass slides. You won't be able to pull them apart. So you need something to reduce the surface tension and make those alveoli inflate. And actually, to give you a better example, imagine you had a water balloon, which you put little bit of water inside. And then you try to pull the balloon apart. It becomes very, very difficult, isn't it? So you have to actually blow into it in order to allow the balloon to expand. So the same way, we need something there present which will reduce the surface tension and allow the alveoli to expand. Otherwise, you'll have a problem. So that is this surfactant. So what surfactant does is it lowers surface tension. So surfactant lowers surface tension. And hence, by lowering surface tension, it allows the alveoli to expand. If you look at this picture here, this shows you alveoli without surfactant. Can you see all these walls are so close to each other? Can you see this here? And this is an alveolus with surfactant. So can you see how nicely enlarged they are? Okay. In fact, we have a term for whenever the alveoli are collapsed, and I may as well reintroduce it here. The term for collapsed alveoli is known as atelectasis. Collapsed alveoli. Now, surfactant production starts very early. It's about 20 weeks. By about 28 weeks, it's kind of a bit adequate. And the older the child gets, the more the surfactant is. So that's why when babies are born prematurely, they don't have enough surfactant production. So with the result, their lungs are collapsed and they have to be kept in an incubator. And you have to actually give them artificial surfactant as a nasal spray. We often give them steroids, which help to increase the surfactant production. Now, if nothing is done, no help is given to the children, what will happen? Their alveoli will be collapsed. They will be in respiratory distress because if they are collapsed, they can't breathe in properly. So they suffer from something known as IRDS. And does anyone know what IRDS stands for? It's called infant. I is infant. Respiratory distress syndrome. And this is due to lack of surfactant in a baby who's born, and usually happens when the baby is born prematurely because then the surfactant production is not enough. So let's review some of the things. So a 3-year-old child, you have this 3-year-old child who's prone to lower respiratory infections and has had several episodes since his first birthday. Do you think this will affect his respiratory function in the future? Yes, excellent. And this is the reason why we are always worried about children. Whenever they even get a cold, we don't want it to go and become a ear infection, which you'll see later. And we don't want it to progress down because, again, you interfere with the development and then you compromise the respiratory function. Now, if there is lack of surfactant, what do you think, where is the actual problem? Is it there's a problem with gas exchange, or is there a problem in conduction of air or production of something known as pleural fluid? You know, the pleura covers the lungs. Okay, the correct answer is gas exchange and not conduction of air. Remember, look at it, respiratory zone. Remember we did respiratory zone, which is where gas exchange occurs. Alveoli are part of the respiratory zone, which is where gas exchange is occurring. Where is the problem? If there's no surfactant, the problem is where the alveoli are not going to enlarge. If they are not going to enlarge, that means they are going to be collapsed. And remember the gas exchange, I showed you that I drew the picture for you. So in between the alveoli in the interalveolar septum where the capillary wall was, this is where gas exchange is taking place, right? So here if you have a collapsed alveolus like this, and here's the capillary, and you have another collapsed alveolus, can you understand there's no air inside, no oxygen there, so where is the gas exchange going to occur? Okay, so it's gas exchange which becomes a problem, not conduction of air. Conduction is going to occur normally because it's going to come all the way down from the nasal cavity up to the bronchiole. When it reaches the alveoli, it finds that the alveoli now you cannot inflate some of them, right? So there's going to be the problem will be in the gas, which is why they have the distress, respiratory distress syndrome. Let's look at the nasal cavities. So we have actually got the external nose is made up of two parts, cartilaginous and bony. All the cartilages here are hyaline in nature, and then this is the bony part. And we have two nasal cavities which are separated by a septum in between. And if you look here, you are looking at one nasal cavity here, and imagine there is the septum which is present, and I have removed the septum. That's how you'll be able to see one nasal cavity. So imagine if I had the septum present here like this, okay? And this is the septum. And now I remove the septum, so now I can look into one nasal cavity. When you look at your nose inside, all that you can see actually is you're only looking at this area. You can't look further back. But if you look at the lateral wall of each nasal cavity, it really has 3 shelves of bones, which these shelves are known as conchae. Each of these shelves is known as a concha or also called a turbinate. Concha and turbinate are synonymous terms. So it's called a concha or a turbinate. So you have a superior concha, a middle concha, and an inferior concha. Below each concha is a space present. The space is known as a meatus. Meati for plural. So you have superior meatus, middle meatus, and inferior meatus. Do you see that? Now your entire nose is surrounded, if you were looking at the nose from the front, so if I was to just draw the nose from the front like this, right? Here you have sinuses all around, and these sinuses are known as paranasal sinuses. Para meaning by the side of. So in the face, so if we just take the face like this, right? You have a sinus up here on top. You all know you have a sinus headache. That's the frontal sinus. You have a sinus here, which you all know over your maxillary bone or in your maxillary bone, called the maxillary sinus. You have sinuses which are present very close to the eyes. So here, if this is the eyes. So you have sinuses present very close to the eyes called ethmoidal sinuses. And you have another sinus in the sphenoid bowl called the sphenoidal sinus. So all of these paranasal sinuses are surrounding the nose, okay? And what really happens, and we'll see another picture where you will see the mucous membrane of the nasal cavity actually goes and lines those paranasal sinuses. Now, these paranasal sinuses open into these spaces because they have to communicate with the nose. So they pour their secretions into that. And you all know whenever you have sinusitis, if you blow your nose, you get a lot of phlegm coming out, right? So here you can see some one or two of the paranasal sinuses. Here's the frontal sinus. Here's the sphenoidal sinus. So imagine actually they have a duct. So the frontal sinus has a little duct which will open down like this. The sphenoidal sinus opens into a part above here. So you don't have to remember where these individual sinuses open, Most of these paranasal sinuses open in this middle meatus, this one here, the middle meatus. And in the inferior meatus is the opening of the nasolacrimal duct. Now this is important to know. You all know because the nasolacrimal duct comes from your eyes. And you must have done this in A and P1. So again, if you draw the face like this, and here's the eye. So if you remember, you had the lacrimal gland, and the tears were made, and you had this little duct which came down, which was called the nasolacrimal duct, because your tears are constantly made and they flow down this nasolacrimal duct and come and open in the nasal cavity. So they help to even keep the nasal cavity moist. When you cry, you all know your nose becomes stuffy. That's because more than normal lacrimal fluid is being formed, and so that kind of passes down the nasolacrimal duct into your nose, and that's why it becomes a little stuffy. Now these turbinates or conchae they're covered by the nasal mucosa, which is pseudostratified ciliated with lot of goblet cells. So they help to increase the surface area of this. They also set up like a turbulent airflow. So when air is coming in, as it's passing through, they kind of set up a turbulent airflow. So air stays in longer. It helps to humidify the air, helps to moisten it, bring it to the temperature of the body. So if it's very cold, so it'll warm the air as well. So that's what the function of these turbinates is. And here I also want you to notice the sphenoidal and the frontal sinus, like I mentioned. And then the other function of the nose, apart from just, getting air to go, being part of the conducting system, remember the nasal cavities all has special epithelium called olfactory epithelium, which was part of the special senses, olfaction, right? So this special olfactory epithelium is present along the roof of the nose, of the nasal cavity. So when you look at this nasal cavity along the roof, so if I was to draw the nasal cavity this way, if you're looking at it, imagine you're looking at a person's nose from in front. So this is the septum right in the middle. So this is one nasal cavity, this is the other. This area, which is the roof of the nose, that's where you have this olfactory epithelium. So this area, which is where the medial wall and the lateral wall meet, this area is where you have this olfactory epithelium. It's a very special epithelium. It can regenerate. The receptors are actually the dendrites of the cells which carry the impulses to the brain, to the temporal cortex. And that's why they can be destroyed, if very pungent fumes or anything go up there, which is why they tell you always need to wear masks. And because the olfactory epithelium is present so high up, that's why you need to, when you want to sniff anything, you have to actually sort of take in a deep breath, because it's so high up, so whatever you're breathing has to go all the way up there in order to stimulate that and for you to be able to perceive that smell. Okay? So here you can see, here are the paranasal sinuses. Look at the frontal sinus. These are the ethmoidal sinuses. This is the maxillary sinus. Okay? And this is the superior turbinate, middle turbinate, inferior turbinate. So you can, when you're looking at it in front, this is the superior meatus, middle meatus, inferior meatus. Here's the nasal septum. And all of these, notice how they will travel down like these. The ethmoidal will pass, this comes into the middle meatus. They pass down this way. And sphenoidal is way behind, you can't see it. And the maxillary sinus has to drain this way. Look at it this way. It has to drain in this fashion. Okay? So notice how these sinuses are draining. So here's a little video actually showing you an examination of these turbinates and the openings.
If we look on the left side of the nose with a thin telescope or endoscope, you see a pink structure to the left, which is the septum. That's the wall that separates the right from the left side of the nasal cavity. On the right side of the field, we see the turbinates. In this case, we're looking at a red middle turbinate. This is bone covered by a membrane that helps to warm and humidify the air we breathe in. Notice we see a small black hole. coming into the upper right portion of the field. That is an opening through which a sinus drains. In this case, the left maxillary sinus drains mucus from the left cheek region into the nose through that opening.
So you can see how the turbinates, and you saw how small that opening was, which is why when you have sinusitis, that it gets blocked so quickly, because the whole area is swollen. Now here, this is the septum of the nose. So when you look at the septum of the nose, the septum is part cartilaginous and part bony. The anterior part, which is this area here, this is hyaline cartilage. And at the back, on the posterior part, it is bony. It's made up of two bones. This one here is the ethmoid bone. And this one here is the vomer. So the posterior aspect is bony. Oh, you can't see that. So this is the ethmoid. And this is the vomer. And here is hyaline cartilage. Now at the anterior end of the septum, and some of you may be prone to nosebleeds, it happens very, very frequently, especially in very warm temperature. And it usually occurs very close to the anterior part of the septum, this area of the septum. So this area here of the septum is actually called Little's area after the person who discovered it. And here you have a very, very rich blood supply. So blood vessels, anastomos, they're not well supported. So with the result, when they dilate or any slight trauma, just like scratching your nose or anything, you can scratch the mucous membrane and maybe erode a blood vessel. It leads to nosebleeds, which are known as epistaxis. And the best treatment is to just pinch your septum, pinch that area between the two nostrils. So if you put your forefinger in one nostril and your thumb in the other and just pinch that area, you kind of can stop bleeding. Some people bleed very, very profusely, especially if they have hypertension or anything, because the pressure is so much, it can start. You may have to pack the nose in those cases. Okay, you saw how those sinuses were draining. Which sinus do you think is most disadvantaged when it comes to drainage of its secretions? Now, but just looking at that picture, you can see. Maxillary, yes. Remember, all of the other sinuses gravity helped them. So here, if you look, gravity helps frontal drains down, ethmoidal down, sphenoidal is kind of way back somewhere there. That also is going down. Remember how I drew the maxillary? It's going this way. Can you see? So its floor is lower than the floor of the nasal cavity. So this, often when you have maxillary sinusitis, it tends to remain for a long time. And in fact, in order to drain it, you have to do something known as postural drainage, where, you lie on one side, so the person, say, lies on this side, if this sinus is drained, so that this sinus then becomes higher up, and then it can drain this way. You put your head this way so that the sinus drains in that fashion. Now here's a little review of the pharynx. We already did the pharynx when we did lymphatic system, so again, a quick review on it. The pharynx is the area behind the nasal cavity, the oral cavity, and the larynx. And based on that, we divide it into three parts: nasopharynx, oropharynx, and laryngopharynx. Its muscle wall is skeletal muscle. And actually, this kind of skeletal muscle is a little different. It's involuntary to a certain extent. The lower you go down, the more involuntary it becomes. Because if it was voluntary, you could kind of move your food up and down the larynx. You don't up and down the pharynx. You don't want that to happen, because when you're swallowing your food, this epiglot, this cartilage here, this has to form a lid and close down like this, so that food goes down into the esophagus and will not go into the larynx. Otherwise, you'll choke, right? So since breathing stops for some time, you want it to occur really fast. So that's why they want to make it involuntary, so you have no control, so that food can go really down. Upper areas, for example, let's say the oropharynx and nasopharynx, you know that if you tickle the back of your throat, you can throw up. So, as you keep going down, the muscle still remains skeletal but goes out of your control. It becomes more involuntary. Now, the epithelium differs in these three areas. It's very similar to what is in front of it. So, in the nasopharynx, it's pseudostratified ciliated epithelium. In the oropharynx and laryngopharynx, it's stratified squamous non-keratinized. And as a quick review, you guys should remember, in the nasopharynx, you have the pharyngeal tonsil present. And you also have the tubal tonsil. If you remember, over the eustachian tube, you have this tubal tonsil present, right? In the oropharynx, you have the palatine tonsil. And which tonsil is this? Lingual tonsil, that's right. And in the laryngopharynx, there's nothing special, no special structure. So here again, you can see some of these structures. So in the nasopharynx, you can see the tubal tonsil, you can see the pharyngeal tonsil. Another very important structure which is present is here, which is the opening of the pharyngotympanic tube, or also known as the auditory tube, or it is also called the eustachian tube. So it has many names. So you have the eustachian tube, auditory tube, or pharyngotympanic. That's a really good name because it kind of tells you what is the function. It connects the pharynx to the tympanum or middle ear. So this eustachian tube connects the nasopharynx. It connects it to the middle ear. It helps to equalize, its function is it helps to equalize the pressure between the nasopharynx and or between the middle ear and the outside through the nasopharynx. So sometimes, when you go up in an aircraft, at pressurized cabins, and sometimes you feel your, ears are blocked and you just swallow. What you're really doing is opening and closing this auditory tube because it has a muscle around it, and you equalize the pressure in the middle ear with the outside, with the atmospheric pressure. So that is its main function. In children, this auditory tube is shorter and more sort of horizontal. So that's why any middle ear infection which occurs can trap, or rather actually from here, from the nasal cavity, if the child gets a cold, can you understand the cold can kind of come back into this nasopharynx? From here it can go into the eustachian tube, and where do you think it will end up? In the middle ear. So that's why colds in little children are often accompanied by middle ear infections because of the way this spreads. Okay? Here in the oropharynx, you can see the palatine tonsil and the lingual tonsil. This should have been here, the lingual tonsil, and the laryngopharynx has nothing special. Okay, well, let's do a review here. Which of the following are present in the nasopharynx? So this is why looking at the picture images is really important, because that kind of will always make a visual impact. Very good. Pharyngeal and tubal tonsil. Excellent. Okay, here another review. Infections from the pharynx can spread to the middle ear through eustachian tube, not the tubal tonsil. The tonsil is just lymphoid tissue there. It's the tube, an opening with the tube which is connecting the middle ear with the nasopharynx. So it's through the eustachian tube, not the tubal tonsil. Okay, we'll stop here.